Well, first of all, I want to thank you for inviting me here. It's good to meet my colleagues here at this campus. I mean, you say that you probably don't see enough folks from Belknap, and I feel the same being isolated at Belknap. So this is working out very nicely, and I'm honored to be here. So I'm not only looking forward to telling you a little bit about my current research project, which is an extension of my doctoral dissertation, but also talking with you about the issues that come up in my presentation and in the work that I've been doing. The study that I'm going to tell you about is ongoing, and data collection is actually less than halfway. When I gave Daryl the topic of my presentation, I thought that I might be a little further along than I am now, but the data collection, as I said, is about halfway complete. So what I'm going to be presenting actually are preliminary themes rather than findings. I mean, I am going to tell you what I found, but as I continue to do data collection, it's likely that some of these things will be modified a little bit. And as preliminary themes, they'll provide hopefully a starting point for a discussion in just a short while. The title is a somewhat provocative one, and one that I chose because I will be talking about issues of equity. I will be talking about issues related to whether or not paying mental health consumers for participation results in perverse incentives, and I'll talk about what that means in a second. But mostly what I'm going to be talking about is the motives that these mental health consumers have for doing the work, the paid work that they do. And that will be the focus, actually, of the topic that I'm covering today. So the topic is within the broader area of lay professional relationships in health and in mental health. Public-private partnerships which foster lay and professional partnerships in publicly financed healthcare programs have gained in popularity over the last couple of decades. You may have heard the term joining up, which is used by folks over in Europe as well as in Canada to talk about these public and private partnerships. Here in the U.S., you may have heard about the new public management movement, which is encouraging partnerships between the public and the private. And oftentimes these partnerships involve the lay public. In the area of health, it can include patients. In the area of mental health, it may include consumers. So there are a variety of forces that are moving towards increasing lay participation in publicly financed health and mental health programs. And yet, despite that, we actually know relatively little about the ways in which paying folks using fiscal incentives relate to broader values embedded in public-private partnership models. Similarly, little is known about whether and how stipends foster or hinder lay involvement in the delivery and planning of health and mental health services. And more specifically, the relationship between these incentives and participants' intrinsic motives really haven't been examined. So we don't know how payment relates to the reasons that people actually engage in working in some of these partnerships. So as these movements have been happening towards increasing lay professional participation, at the same time we've seen notable efforts, especially in mental health, to incorporate the paid involvement of the public. The Surgeon General's report on mental health in 1999 was instrumental in a number of ways. It outlined the history of consumer involvement in creating mental health programs, something that many people had little knowledge of and still occasionally have little knowledge of. But the report also was significant in that it concluded by stating that all services, all mental health services, should be consumer focused. And also oriented towards recovery. So recovery was being talked about for the first time. Prior to the Surgeon General's report, the overriding consensus really was that if you had a mental illness, it was lifelong, and it would endure at a pretty steady rate, and recovery really wasn't all that possible. By 2003, the final report of the New Freedom Commission on Mental Health took the call from the Surgeon General's report one step further, and the Commission stated that opportunities should be generated to involve consumers and families fully in orienting the mental health system toward recovery, and that this orientation should occur in planning, evaluation, and service delivery, so throughout the entire mental health system. So you can see that a couple decades ago, we saw the initial call for consumer involvement in mental health services, and that call is continuing today. In part, the call for consumer participation in mental health is important because of the scope of mental illness. And as I'm sure most of you, if not all of you, are aware, mental illness isn't an isolated condition or experience. Many individuals and family members experience its effects every year. One of the most commonly cited statistics is the first that I have on this slide, that 1 in 4 people have a diagnosable mental disorder in a given year. Doesn't mean that they're actually diagnosed with that disorder, and it doesn't necessarily mean it's a full-blown serious mental disorder, but that if the person saw a mental health care provider, they could be diagnosed with a mental health condition. Serious mental disorders are less commonly found. About 1 in 17 people have them, so still a sizable amount of the population. And when you compare it to some of the other chronic and terminal illnesses that we have in this country, you can see that it is pretty common. 2 times as many people live with schizophrenia in this country than with HIV or AIDS. So a significant health issue across this country as well as in other countries. So my current research, and what I'm going to share a little bit with you today about, focuses on consumers as well as family members of consumers who are paid either a stipend or a salary to work in public mental health programs. And with one of the job requirements being that they identify as a consumer representative. So their occupation is predicated on their personal experience and on their identity as a consumer or as a family member of someone who has a mental illness. And these individuals are called mental health consumer consultants. So I'll step back for just a second and fill in some of the necessary academic details about the theory and about what I'm studying. Paying for lay citizen participation is actually debatable in the literature. There is a debate primarily in economics and organizational studies around whether or not participation in groups can and should be maximized through payment. And by groups, I mean a range of groups, so not only volunteer groups, but also quasi-volunteer groups like advisory boards, as well as paid employment. And so I'm focusing on kind of the middle ground that moves from being a quasi-employee, a consultant, all the way up to a full employee. So a little bit about this debate about whether or not it's a good thing to pay people specifically to participate in public programs. The pro first, some theory and research supports agency theory. And here, incentives or paying people is believed to enhance the performance of individuals and at the same time produce systemic effects, such as increasing the efficiency of services or increasing equity and respect for the participants who are paid to be part of these programs. And in the same vein, according to the logic of collective action, the use of incentives would encourage participation and reduce the problem of what economists call free riders. So people who receive benefits from a public service but don't do anything to give back to that service. So there's a solid economic as well as organizational argument for paying people to participate in public programs. But not surprisingly, there's just as weighty an argument on the other side, which argues against paying folks. The use of incentives is contested actually on several grounds, and some of them can be found in popular business sources, such as this book that is featured in the slide, Drive. And some of this research suggests that providing incentives may actually undermine the intrinsic motives, or the motivations that people innately have within themselves. And these motives can be related to things like deriving pleasure from engaging in the activity, or receiving satisfaction from successfully performing duties in the public sphere. So if you pay folks, it might diminish some of the pleasure. It becomes work. It also could diminish some of the satisfaction from performing a job to its maximum. So financial incentives here are believed to act as what is called extrinsic motivators, not related to the activity or to the group membership, and they actually may become more important than the actual work. And so what interests sociologists and folks like me, I don't speak the language of intrinsic motivations and extrinsic motivations, and you're probably breathing somewhat of a sigh of relief that the whole talk isn't going to have that language in it. What we're interested in is understanding how social behavior might change as a result of being paid to be a part of a group that is designed to benefit the public. People might participate where they otherwise would not have. And in fact, what might even be more of a concern is that people who join whose goals are not aligned with the group's, and their goals might run actually counter to the group's goals. So it ends up being counterproductive to pay people to be in groups. So this, in a nutshell, is the academic argument for pro and con for paying folks to be part of publicly financed programs. And actually, empirically, we know very little about how stipends or other forms of payment work in the areas of health and mental health to encourage lay participation specifically. The literature has very little to say about these issues that I've posted on the slide. Much of the current work on incentivizing participation is based on rational choice theory, which assumes that people operate on the principle of selecting the most efficient means to achieve a desired end, and that people consistently act strategically. So the theory says if you pay people and you link the payment with achieving these certain goals of participating in a public program, that will be a rational choice, and you can understand how people participate. But the theory in many ways is distinctly asocial. There are benefits to the theory, but there are ways in which it doesn't consider the many potential non-rational or unconscious basis for social action. So it requires a contextualized social analysis to understand what does happen when you pay people to be part of specific programs. I use what's called a constructionist perspective. This is a qualitative perspective that many sociologists use, and the research project that I'm currently working on addresses some of the issues that you see in this area. I examine how mental health consumer consultants understand the stipends and the salaries that they're paid. And the sociologist C. Wright Mills has spoken about these types of issues, the understanding of motives as situated motives, that we need to understand the ways in which people construct culturally bounded accounts of why it is that they participate in specific activities and how it is that they describe their actions. So as a qualitative researcher, I don't start with a research question or a hypothesis. I have some analytic questions that I go into the field and I kind of poke around. I ask people, well, what do you think about this issue? And they come back and they tell me a little bit about their story, and then I follow up with additional questions that are related to what they actually tell me. So what I translate from academia to everyday lay language has to do with what sociologists call these situated motives. I ask people, you know, what social meanings do you have for participating as a mental health consumer consultant? Why is it that you do the work that you do as a mental health consumer consultant? And then within that context, I ask, what social meanings do the fiscal incentives, the stipends, or the salary have for you? You may have these other reasons that brought you here to participate in the program, but what meanings do the payments have for you? And how do those payments act? Do they encourage you to participate fully in the program, or do they act as perverse incentives? Do you end up doing things that the program that you're involved with doesn't necessarily approve of, or that may run counter to the program? And of course, the questions aren't worded as bluntly as that. They're worded in everyday conversation, but those are the issues that I'm getting at when I speak with people. So I handed out a sheet which is a little different than this. The sheet I handed out to you is the bare bones of my research designed to kind of help you follow along as I'm talking. I started this research back east when I was collecting my dissertation data on children's mental health. And at the time, my focus wasn't on mental health consumer consultants. I wasn't interested in this issue of what happens when you pay people. It just ended up that some mental health consumer consultants were part of my sample, and I became intrigued by some of their stories and about some of the issues that their experiences raised. So I'm beginning to expand on that work, and I've started to collect additional data here in Kentucky to address some of the analytical questions that I just went over in the previous slide. This table contains information about the different types of consumer consultants that I'm including in my study. And because I'm still collecting data and really don't have enough cases to talk about the differences that occur between these cases, I'm going to talk about all three of these groups as a whole. And I'll speak of them, the term that I'll use to talk about the three groups when they're combined is consumer consultant. But you should know that there are some distinctions between these three groups. There are essentially three groups. There is a group that are consultants who are paid stipends to perform discrete tasks. So they might be paid to attend a meeting. They might be paid a stipend to be an advisory board member. There's another group that are known as consumer advocates. They may be paid part-time or full-time, and generally it's part-time, but occasionally it's full-time. And they have a salary. They're paid through either grassroots advocacy organizations who are interested in mental health, and so they hire consumers to work with them. Or in some cases, they may be funded through the state to work with the advocacy organizations. So they're actually state employees, but they work with the advocacy groups. Here in Kentucky, I've been focusing some on peer support specialists who also receive salaries. They're mental health consumers who go through a training, and they're hired by mental health treatment agencies in the state. It's important for you to know about the two organizational contexts in which these consumer consultants work. And so I'm going to tell you briefly a little bit about those organizational contexts, and then move on to some of the life stories of these folks and tell you about what it is, why it is they do what they do. But first, I want to explain what community collaboratives are. How many people have heard that term before? Okay, so a few folks, but for the most part, not many, and that's kind of common in groups. I always like to check in and see what the case is in any particular group. So I'll tell you about community collaboratives first, and then a little bit about peer support specialists, and especially peer support specialists in the area of mental health. Okay, so both the consultants and advocates work in what is known as systems of care. And neither the consultants nor the advocates are technically consumers themselves for the most part. Oftentimes they are parents or other family members of children with a serious emotional disorder. And while some happen to also be mental health consumers themselves, that's just by chance. Their primary involvement in the program occurs because they have a child who has a serious emotional disturbance. And I've included them as consumers in this study because they often are considered secondary consumers. That's a term that's often used. They're very closely involved in the mental health care that their children receive. They may actually receive family therapy as part of treating their child. And so they are consumers. They often have gotten involved in mental health care as a consultant through what's known as systems of care. Systems of care are a strategy for delivering community-based services to the children who have serious emotional disturbances. This integrated system was developed as a strategy in the 1980s, and the idea was to kind of cobble together services in a community that could serve children who have these needs. And typically the needs of these children were very diverse. So it wasn't just mental health that kids need services with. They also might need special educational services. They might be involved in the juvenile justice system. Faith-based communities were often tapped within the system of care to become partners. So the idea was that you could build linkages with the community and build a support system for these children. Family members, as well, including parents, were often significantly involved in these systems of care. And they were significantly involved and continue to be significantly involved in what are known as community collaboratives. There are three components usually to systems of care. There's a management team that typically oversees how these local systems of care work. And then there are child-specific teams that provide treatment to children who are receiving services. But the community collaboratives are kind of a quirky and unique model. They're essentially local planning boards. And they're the group that I'm interested here in for my study in understanding how parents and other family members work with these groups as consultants and as advocates. It's a public group. It's open to the entire community. Anybody can walk into these public meetings. And one of the key principles of the system of care is that they're family focused. It's highlighted in the model, and the goal here is that families and surrogate families, so not necessarily just the biological families, but whatever constitutes a family for the child, should be full participants in all aspects of the planning as well as the delivery of the service. So it's an ambitious agenda to include parents in these models. The typical responsibilities of a community collaborative are also pretty ambitious. Typically, community collaboratives are charged with assessing the need for children's mental health services in their community to see if there's unmet need. They're also charged with coordinating the behavioral health services and the supports in the community, so building that linkage that I talked about, and expanding the network of local stakeholders in children's mental health. So drawing people in. By having a visible group, you can draw in stakeholders who might not be connected. And then also to secure additional resources as necessary and available. So needs change, and the resources also would change, and the community collaborative is a key participant in doing that. So you're probably still asking, well, what are these groups? What do they do? It sounds kind of odd. Typically, these groups meet about once a month for an hour, maybe 2 hours. And the agenda is pretty typical in any of these groups. A single collaborative will serve a geographically demarcated area. It might be a single large city, or perhaps it could be a regional collaborative that serves several smaller towns, and that occurs a lot in rural areas. In Kentucky, there are 18 regional groups, and the groups, as I said, tend to meet once a month or so, and the bulk of the meeting is actually spent on updating participants and community members about new and existing services for children with mental health needs. So you can see there's an announcement section typically where new services are announced. There are also administrative updates, so a discussion about how many kids are being served in the community and if there's any capacity for serving additional kids who need help and who currently aren't in the system. The federal government, as well as foundations, have provided funds to start community collaboratives and systems of care across the country. The funding actually began in 1984. And Kentucky was one of the earlier states to receive funding, not from the federal government, but from the Robert Wood Johnson Foundation in 1989. And by 1 year later, in 1990, there was a statewide system of regional interagency councils, which have these partnerships between mental health providers as well as other providers in the community and parents. Each of the 18 regional interagency councils have a parent or a family member who sits on the council and who is paid a stipend. So in Kentucky, I'm looking at the REACs, as they're called, the regional interagency councils. In the eastern state where I collected my data, it goes by a different name, community collaboratives, but they're the same type of group. Okay. So the third group of consumer consultants in this study were peer support specialists. And I'll tell you a little bit about this program. It's a little bit more straightforward. And these consultants work with adults with mental health disorders. So the folks who worked in the community collaborative served the child sector. Peer support specialists that I'm interviewing anyways focus on adults with serious mental disorders. The peer support specialists actually provide individual recovery-focused services to other mental health consumers, and the services that these folks provide include things like housing assistance, occupational counseling, as well as crisis management and anger management. So it's a wider range of services that peer support specialists can provide. The nationwide system began in Georgia back in 2001, so it's only 10 years old. And it emerged as a result from the Surgeon General's report, which emphasized recovery and that I mentioned earlier. Not all states have peer support specialists, but those that do typically offer a 5-day training program leading up to a certificate. And Kentucky does have that certificate program. Some states do then go on to employ peer support specialists as part of their Medicaid reimbursed programs. Kentucky currently doesn't have the Medicaid reimbursement part. There's been an amendment to our state plan that was submitted 2 years ago, and that amendment is still pending approval. So what that means is that here in Kentucky we have about 175 peer support specialists who've been trained, but only 30 of those have actually found part-time employment in private, usually nonprofit service organizations that find creative ways to fund them that don't involve Medicaid funding. So out of the state, there are potentially 173 folks I could be talking to in this group, 30 of whom are currently employed. So I've completed 12 interviews so far. You can see on the slide kind of where they fall. 8 were conducted in the Northeast. So far I've managed to conduct 4 here in Louisville. It's a small number. Qualitative research, usually you're looking for 25 to 30, perhaps 40. Any more than that, you kind of have overload listening to people's stories and you can't really analyze them. So I have the 12. I'm looking to get 30 to 35 and also to interview some service providers. So what I want to again emphasize that what I'm going to be sharing with you today is preliminary. They're themes that are emerging from data and that things will likely change as we move forward. There are 3 primary themes that are emerging from the interviews that I have conducted with the 12 folks. I asked a series of very open-ended questions to people. And some of the questions I asked included, why they decided to become a consultant or an advocate or a peer specialist, what events led them to make that choice. They could make other choices, but why was it this that they chose? What do they like most about what they're doing in their job? What they saw themselves doing in the future? And then also what meaning the payment that they receive for doing these types of services has for them. And out of the 12 interviews that I've completed, there are 3 themes or topics that are emerging. First of all, what are the meanings that consumers have for being paid? And are they, is the payment acting as a perverse incentive and causing them to participate only to receive the funds? And secondly, what are their motives? So more broadly, stepping back and looking not just at the money, but are there other things that draw them to being a consumer consultant? And then thirdly, resistance that they've met in being hired or learning about others being hired as consumer consultants. So first of all, consultants, advocates, or peer support specialists spoke about the social meanings that the stipends had for them. And for some, payment did have an extrinsic purpose. It served a function other than meeting their internal needs for being a consumer consultant or an advocate or a peer support specialist. It helped meet everyday expenses. The stipend or salary actually helped them to meet their basic survival needs. Part-time peer specialists and consultants, especially those on disability, find that finances can be pretty tight. So you can see Laura, who's a peer specialist, said, well, for one thing, on disability in Kentucky, you're living way below the poverty line. So it's money for extra groceries. It's really a financial boost. So there is an extrinsic reason, something outside of the actual work, that motivates people to become a peer specialist. And Denise actually wasn't the only one. There were several others who went on to say that, yes, it was important for them financially to have these stipends and to be paid a salary. But she also emphasized that she was proud that she had never been on any type of public assistance. Even though the stipends and salaries help pay for life's necessities, it's not viewed as a type of assistance. She says, for me, it was to support myself and to be able to actually help people and pay my rent. So a combination of helping as well as meeting her own needs. For at least one peer specialist, his salary was actually an extrinsic reminder, something outside of the program that reminded him that his job potential was less than it was before he became mentally ill. He recently was diagnosed with bipolar disorder within the last 18 months or so. And Thomas was the only one out of the 12 people who I've interviewed so far who spoke about the salary being too low and not meeting the potential that they saw for themselves. He does have a master's degree in MBA, but others with whom I spoke also had college degrees, and some had significant work experience. Thomas, even though he's not entirely happy with being a peer specialist and not maximizing what he thinks his skills could be, he's recognizing that it's a good place to start, he says, and that compared to some of his recent post-illness work placements, he says being a peer support specialist is a whole lot better. So there's kind of an ambivalence about being a peer support specialist, and Thomas exemplifies this, pretty strongly. So in all of this, stipends do work as an extrinsic motivator. We all work to pay our bills. There's nothing, terribly unique about that. So the question really is, well, do they act as perverse motivators? Do people end up going in droves to these groups and signing up to receive stipends and not being terribly interested in the work that these groups are doing? A few consumer consultants did offer accounts of other consumers, not themselves notably, but other consumers who were trying to game the system and obtain money without really having an interest in doing the work that these groups do. In the middle of speaking to me, Nora, who was a consultant in the children's mental health group, said, "Oh, no one has told you this dirty little secret?" And then she emphasized that these parents weren't interested in the collaborative's work, but were merely looking for ways to increase their income. Here, one parent asked her, "Does this collaborative pay stipends? That would be extra gas money for me." And it wasn't in the interest of meeting her basic needs. It was, to generate more income without having an interest in the work that the group was doing. So perverse motivation does occur. But what was interesting here was Nora's response. She says, it's not designed that way. We really shouldn't abuse it, because if it's abused, then it means that that when you really need it, then it won't be available. We want to use it the right way and make the system better. So Nora enforces what she sees as the right way to view and use these stipends. She holds them pretty near and dear to her heart, and she doesn't want to see those stipends go away. Similarly, Denise spoke about her role as a peer specialist supervisor in another state, and she told me about an instance in which she tried to right a wrong that she observed. There were other peer support specialists who were actually misappropriating food and other resources from the program for their own use. And she said, these other peer support specialists were actually stealing the free food rather than giving it out to people. They were using the company vans to do their own running around at Walmart. And then as a new regional supervisor in another state, not Kentucky, she said, I had to step in and say, no, you're not doing that. I don't think this job is a good fit for you. So she not only put a stop to their doing these activities, she really was very clear that she did not want these individuals participating in the program. And she fired them from the program. So that's a very clear-cut example of putting limits on perverse incentives. And in addition, there are de facto caps on the stipends and the salaries, the amount of money that most consumer consultants can earn without being penalized. Laura describes the line she has had to walk in watching the number of hours she is paid for so that she can ensure that she doesn't work too much and jeopardize her Social Security retirement benefits. And so you see, when you put these kind of de facto caps along with the fact that consumers report that they monitor the inappropriate action of their peers, it strongly suggests that while perverse incentives do occur, it's not terribly widespread. There's enough in the system that the perverse incentives aren't an overriding or very visible force in any of these groups. In fact, some of the most financially needy members of the community collaborative I observed a few years ago did not sign up to be consumer consultants. They clearly could have used the money, but they didn't do that. There was one woman in particular who stood out to me, Sherry, and these are all pseudonyms, they're not real names, was a single mom. She had two young boys, both of whom had serious emotional disorders, and she had to manage on a little over $500 a month to pay all of her expenses, which was quite a struggle for her. And she, in fact, did not have enough money to even purchase a refrigerator. And so it was very tight for her. She could clearly have used the stipends, but she chose not to do that. In fact, those who were paid often said they felt such a strong commitment to what they were doing that they would participate even if they were not paid. Laura is somewhat typical of these folks. She said, I do a lot of voluntary stuff. I always work more than what I bill. I can only bill so much, but that doesn't mean I stop. And then she laughed. She said, my husband calls it my charity work. So she's very invested in these programs, and the money isn't the primary reason that she is involved in these groups. In fact, the symbolic value of the money that they receive is pretty important to these consumer consultants. It's not just the money, it's what the money means to them. So as this next section details, mental health consumers spoke about these symbolic meanings of the stipend or the salary, and this tended to be much more important for them than the actual dollar amount. So in the interest of time, I'm only going to talk briefly about the first two, because the latter two were only described by consultants in the community collaboratives and not by peer support specialists. And so the first two probably are a little bit more important. And the first is with equity, the symbolic value of the stipends or the salary as demonstrated for equity. Terrence and other lay members identified the presence of stipends as a sign of equity, and he didn't use that word, and he didn't mean that consumers needed to be treated or reimbursed in the same way or dollar for dollar as professionals. What he meant was that accommodations should just be fair and just. So when I use the word equity, I'm talking about fair and just treatment. I'm not talking about similar or equal treatment. Terrence said, you want parents at the table so that they're an important part, pay them flat out. Everyone else at the table is getting paid for it. And that's literally true in these groups. Other folks are being paid. He says, show them something, accommodate them somehow. So, in fact, not being paid might cause some folks like Denise to stop participating. She said, if I'm doing the same work as a case manager and I'm not getting paid, but yet the case manager is getting paid, it's going to be a letdown, and I'm not going to continue doing it. But interestingly, not everyone I've interviewed has agreed that the stipends and salary were signs of equity. So the data is messy here, which is kind of an interesting thing for a qualitative researcher to come upon people who have very different things to say about the same issues. And as I go forward in collecting data, I'm going to try to tease some of these issues apart. So Laura, for example, makes a distinction between part-time consumers and full-time professional providers. And she thinks that that's important, that she says, I think if she's talking about other consumer consultants, were hired full-time, that it would be true that the salary would be a sign of equity. But I don't think, as long as they are paid part-time, that the providers in Kentucky will see them as equal. So there's a way in which not being a full-time worker is seen as less than. Denise, on the other hand, had yet a different understanding. She believed that case managers were concerned that peer specialists were competing for their jobs, and she disagreed that equity really existed. In providing peer specialists a salary, the case managers found evidence for their worry. Peer specialists weren't tangential consultants, but they actually were potential competitors with the case managers. So in kind of a convoluted sense, this too is a sign of equitable relationships. Only those who have comparable positions can really compete with each other. This issue of whether or not payment really is a form of equity is an interesting one. It's one reason I included it in the title, but it is, as I said, a messy issue. What's a little bit more straightforward are these issues of respect and credibility. The use of stipends and salaries showed respect for consumers' abilities and actually bolstered their credibility to others. They demonstrated the employer's belief that consumers could and would be competent participants in the organizations. As Laura said, I think being paid gives them some credibility, helps their self-esteem. It also gave the employer's credibility. As Denise points out, I think that tells other consumers it's okay. They see that the providers are working with the consumers, that the providers are actually hiring consumers to work with them. And it gives folks out on the street reason to actually come into some of these service centers and receive treatment. So the symbolic value of stipends and salary are really important to these consumer consultants. They signify equity, respect, and credibility. How are we doing for time? I don't...
It's about 13 minutes up.
13 minutes up. So I'll go for about another 5 minutes, and then we'll stop and talk a little bit. I asked folks why it was that they did the work that they do. And interestingly, when they were asked this question, the participants so far have mentioned a whole variety of motives. I've put 6 or 7 of them up here, and none of these actually refer to the money that they receive. That really is kind of a side issue. Some of these motives, interestingly, position the participants in their role as consumers, especially the first one, to be in a therapeutic environment or to repay folks who actually helped them as they were going through their therapy process. And others were more aligned with their roles as professionals or advocates. And so what I want to do is talk just briefly about the first one, about therapy, and then, if we have time, the last 2. Participants said that being a consumer consultant was therapeutic for them as well as for their family members. It kept them from, as Thomas said, ruminating about your problems or being a chain smoker. For parents like Nora, it often helped them to take their mind off of their child's mental illness. And as she said, it gives me something. It fills me. There's a therapeutic benefit for her in doing this work. Furthermore, the nature of consumer consultant and peer specialist jobs enabled consumers to be themselves and not be concerned about hiding their history with mental illness. Thomas said, first of all, one of the reasons why I enjoy where I am is that everybody already knew me from going through the program, so I don't feel like I have anything to hide. His mental illness, as well as other aspect of his life is well known to folks. He doesn't have to explain that part of himself. Also, occasionally consumers do suffer relapses of their illnesses and sometimes are hospitalized. And when they work as a consumer consultant, if they relapse, then they say they feel less worried about taking time off. For Thomas, he was concerned about the side effects of his medication, especially the tremors in his hand, and that he didn't have to worry about those things when he worked in a therapeutic environment. Consumer consultants expressed other motives for being a paid consumer representative. By drawing upon the expertise of the consumers, the mental health system reaches out in ways that other mental health professionals can't. Denise is a recovering drug addict who has worked as a prostitute in the past, and she's had ongoing mental health issues since she was a child, a very young child. And she says when they're with the psychiatrist, they can't really be as open because they don't want to shock people. They're embarrassed. How am I going to tell a straight lady that I'm prostituting? And yet, when these same people see Denise, they feel like they can be very open, and Denise is able to help them become integrated into the system and learn how to trust other providers in her organization. Still, other consumer consultants speak about their work as a way to give back to others in the community. Some, like Nora, did receive a helping hand when they were seeing their child through mental health services. But others, like Patty, reports that she felt she was alone and she couldn't find help, didn't know where to turn. And the phrase that I often hear is, I want to help others to let them know that there's help out there. So in a real way, there are some altruistic motives that the consumer consultants report for the work that they do. The last thing that I want to mention is some of the resistance that consumer consultants report in their being hired as paid workers in the mental health system. Despite the number of deeply held motives that they had for wanting to be part of the health system, they report some obstacles. One of them is that a large majority, according to Laura, of community mental health centers still have regulations against hiring consumers. So that even if individuals wanted to hire a mental health consumer, there are agency rules that prohibit them from doing that. I'm going to skip over that one. Even organizations which were very successful in paying consumers and family members reported some resistance. Terrence said when we first talked about it, eyebrows were raised. And generally, there are two concerns that people voice. One is that, these are volunteer groups, and to some extent they are, but to some extent they're also paid. So the argument is these are volunteer groups, why should we pay the public to be in them? The second argument is that parents will come only for the money, and the money could be spent better elsewhere. And Terrence's group overcame these objections, but it's not clear how much unvoiced resistance might remain. There might still be resistance there, even though they've succeeded in stipending parents. So summing it up, it's important to emphasize again that this work is preliminary. The themes are just that, themes which emerged from a dozen in-depth interviews, and they may change over time and as I interview more people. But right now, participants have identified an entire series of reasons why they work as consultants, advocates, and peer specialists, and most have to do with the benefits that they derive from the work, not from the pay. In fact, many participants found the symbolic value of fiscal incentives to be at least as salient, if not more salient, than the monetary value. And while few in number, the study has identified accounts of consumers signing up only for the money, so that does exist. There are perverse incentives. But notably, these incidents were followed by accounts of consumers being reprimanded in some way by their colleagues. So also of interest, though, are the underlying values and social tensions associated with paying mental health consumers. They're performing a service similar to other paid employees, so issues of equity are rightly raised, yet there has been resistance, as noted earlier on, toward institutionalizing these arrangements. We see similar discussions about other public programs in which social values are juxtaposed with whether or not payment should be received, and foster care is a good example of this, as well as paying family caregivers in Medicaid and Medicare. But complicating the picture for mental health consumers is a unique facet of their experience. Consumers are on their own journey to recovery. For some, the journey is straightforward and even, but for others, it's cyclical, and they alternate between times of wellness and times of illness. And that really complicates their role as a partner in mental health service delivery and may further challenge ideas about recovery held by their colleagues who are clinicians. Researchers have found that mental health providers do not uniformly accept the notion that recovery from mental illness is possible. So as I continue with this project and interview not only additional consumers, but also some of the providers who work side by side with these mental health consumers, I want to delve more deeply into some of these core themes that I've raised here about recovery, but also about issues of equity and the situated motives that the consumers have voiced for their participation in these programs. So that's where I am with it right now. There's a lot more to tease out. So this is the preliminary work that hopefully will raise some interesting questions and discussion among you in the group.
We have time for questions, and remember to repeat them back into the microphone.
Okay, thank you. Yes.
I'm just interested, were all of your consumer consultants parents of children, or were there some in other situations?
Let me click back to the slide, and
You may have answered that, and I missed it.
I can answer it more clearly. So this is, the consultants all are parents of children. So the 4 in that column all are parents of children with mental disorders of some kind.
Okay.
Does that raise another question?
Oh, the obvious question would be, did you see, I know your numbers are limited, did you see some of the issues and so forth being very different between parents of the mentally ill children and the consumer advocates that were peer specialists who were not parents?
Yeah. I've been reluctant to try to do those comparisons just because the numbers are so small. But that is one thing I want to do, because there are differences not only in the role that these folks play. I mean, the parents are secondary consumers. Interestingly, it's not part of this talk, but there was a lot of resistance to involving family members. Family members were seen as not equal, as really being very challenged. So even though they weren't consumers themselves, a lot of the mental health providers, especially in some of the groups, I studied 3 groups, some of the groups were more resistant toward having parents involved. But the issues on which there might be resistance could differ depending on whether or not you're talking about parents or, advocates who have mental health issues themselves.
The resistance is, I don't want to dominate the questions, this is my last one. The resistance could be the difference in education level, or it could be just the personal connection that is your own child.
Yeah, it would be interesting to see, because you're right, it could be either of those things. It could be education, it could be, the involvement with your own child, it could be a lot of different things. The state systems are very different too, which really further complicates my analysis. So, that's one reason why I really do want to get a nice group of folks here. In the other state, I had a total of 34 people that I interviewed. There were 26 providers and 8 parents. So, it's a little easier to make comparisons between parents and non-parents in that group. Yes.
I noticed among the ones you have here, you have 12. 2 are men and 10 are women.
Yes.
And there could likely be a gender difference here, where the women may have stepped back to give more child care because child care would be needed. And there are fewer men because many of them might be employed in the jobs that they had started before they became a parent of an emotionally challenged child.
Yes.
And also, men and women tend to look at things differently.
Yes, there are likely. The question is there a gender difference? That if you look at the handout that I passed out, there are, I think, 2 men? 2
men, Terrence and Thomas.
Terrence and Thomas.
10 women.
And 10 women, which is pretty typical. The gender distribution there is pretty typical of several of the collaboratives. Somewhat typically, as I said, I observed and collected data at 3 community collaboratives. 2 of them were headed by men, but were primarily composed of female professionals in mental health services. And in the 3rd collaborative, there was a little bit more even distribution. And that 3rd collaborative is actually where you see the majority of the consultants and the consumer advocates coming from. That particular community has a lot of single-parent families. So the mothers who participate in the program and receive stipends or have part-time salaries as advocates were often raising children on their own. And as I'm trying to go through the list of names in my head, I think every single one of them was a single parent who was raising a child on their own. So they did experience challenges in doing that.
I'd like to ask a question outside the scope of your research, and it's about the effectiveness of consumer consultant advocates. And the reason that I'm interested is that in what is friendly called Obamacare, they have a provision for community health workers, which are lay workers, to facilitate the process of non-using residents, into the healthcare system. I personally think that's a good idea based on the notion of social support, but I'm interested in hearing your thoughts or knowledge, about the effectiveness of consumer advocates.
There has been some research done, especially with the peer support program, because a lot of the peer support trainings, the goal of those trainings are to get folks paid through the Medicaid system later on, and so people do need to demonstrate that the program works. There have been several studies done, and off the top of my head, I can't remember the names, but I mean, I can give you my card, I can email you those if you're interested in knowing the sources, but those studies have shown that the peer support specialists are effective in performing the limited roles that they have. So they work side by side with clinicians. They don't work autonomously, and they're charged with doing specific tasks. And there have been comparisons done with, well, what happens in a program that has a peer support specialist with what happens in a program that doesn't. And they've demonstrated some benefits in having the peer support specialist in the program. Yeah. Yes.
I have one question about, these are false names, right?
Yes, absolutely.
The difference in parenting styles between ethnic groups is very unique. Have you looked at anything between ethnic groups to see?
Yeah, the question is about parenting styles and differences between ethnic groups. One of the collaboratives, the collaborative that I'm talking the most about here in the Northeast, was predominantly African American and Hispanic. And the focus of my research really wasn't on parenting styles. So I observed people in the community meetings where they were participants in the meeting. I purposely stayed away from interviewing them alongside their child. I didn't want to get into some of the sticky issues that go alongside asking folks about personal issues dealing with their own children. So my questions really focused on what do you do in this particular group.
Oh, they don't volunteer either. Usually ethnic groups are very different in the way they volunteer for different.
Yeah, I think that it depends on the context. The collaborative that I observed that had the highest percentage of various African American groups as well as Hispanic groups was really mobilized. I mean, it was amazing. These folks were really hardcore community activists. And it was a new collaborative, and yet they succeeded in the state doing things that collaboratives that have been around for a dozen or even 20 years hadn't managed to accomplish. And in part that was because that particular city has a strong history of community activism. So it wasn't the community collaborative starting from scratch. They had alliances to build upon. Yeah. Yes.
I'm interested in hearing what you have to say about what I perceive as a possible discrepancy between the way in which the healthcare professionals would look at some of these mental disorders and want to talk about them, and the way in which the consumer advocates might see them and want to talk about them. The word recovery is a good example, whereas the advocates may really want to hold on to that word because it offers hope and it offers plans for action. The mental health professionals, the psychiatrists in particular, might think that the best thing that can be done would just be to somehow maintain these people at a functioning level with their problems. I wonder how much that might impede dialogue and communication between the two groups.
It can. The question is about the different orientations towards mental health treatment, especially around the issue of recovery. And one of the key findings from my dissertation, and I'll see if it holds up in Kentucky, I still have to get out and talk to providers in these groups, and that's one thing I'm really interested in doing. But in the other state, that really made or broke the ability of the collaborative to get parents involved in the program. If the providers weren't interested in, no one used the word recovery when I was talking to them, but they spoke about people getting better, about parents being able to take on these responsibilities, about consumers being able to be involved in the group. So the collaborative that was voicing things like that did have parent involvement, did have consumer involvement, and did have involvement from the advocacy groups. But there were other groups that were solidly against involving consumers. There was one collaborative that had a parent who had taken on a key leadership role informally and was involved in coming to every single monthly meeting, invited speakers to the meeting, drew up a brochure, and they were electing new officers for the group, and she wanted to run for, I think it was president or co-chair, and the providers in the group spoke about it, and they ended up not putting her name up for nomination because she had clinical depression herself, and they were worried, despite all the evidence, that she could sustain some involvement, that she wouldn't be able to. So it does affect how these groups run, and I'm very interested in understanding more of that, in part also because, recovery's become a buzzword, and so clinicians often give it lip service, but in practice to them, what does it mean? And in some instances, when you talk about some individuals, recovery may mean one thing, it may be very limited. When you talk about other individuals, there may be a whole other degree of recovery that is possible for them. So yeah, it's an interesting issue.
Any other questions? I would say we're done. Thank you so very much.
Thank you.